Hey everyone, welcome back to the podcast. We have another awesome guest with us today who is going to be more of a recurring guest, hopefully. We have Dr. Bo Gu, who is a Canadian American, former cardiothoracic surgeon and emergency physician turned entrepreneur who is taking on how money flows behind our healthcare system. I've gotten to know Dr. Gu a little bit now, and he has some amazing insights into the whole business and healthcare landscape. And so I'm really excited to talk to him. We're going to go over a little bit about his background, but then also just some general hot topics right now within healthcare that I'm excited to get into. So, Dr. Gu, thanks for coming on. And if you could kind of go into a little bit more of your background that I didn't touch on, I think that would be helpful for our listeners as well.
Yeah, thank you, Adam, for the kind intro, and please just call me Bo. And it's a pleasure and honor to obviously be on this show and kind of a little bit about my background. So I grew up in Canada. Actually came to the States right a day before 9/11. So it was a very
Wow.
interesting and difficult time, I think, to come to the country. But at this point, after all this time, feel a bit more of a American than Canadian, despite the recent political tensions between the two countries, to say the least. Come from a family of physicians, actually. So both my parents, my grandmother, were all physicians, and kind of they have went through the typical path of medical school, and it dawned on me at that point that really loved being very hands-on, loved the OR, loved the challenge of whatever the most difficult and kind of meticulous task that was demanded of a medical student or a resident, and really fell in love with kind of the cardiac operating room. So kind of built my whole medical career and resume at that point to kind of go into cardiothoracic surgery training. Fortunately, I was one of the first group of residents to be picked for what we call an integrated program in New York, meaning that we kind of bypass general surgery and the fellowship into a combined program. So had a lot of fun the first year, and then realized after a little bit of time it became a very monotonous routine of doing the same operations over and over. And as much as I love being hands-on operating, I realized I was in a world where people were very um, set in their ways of thinking. And coming from a more creative background, and I also went to art school before in the past, and I did a lot of other innovative things. I felt it was very restrictive in terms of how I saw myself kind of decades down the line. So at the pivotal moment in my life is being invited to a startup competition actually at MIT, and really partnering up with engineers, product, MBA students to really work on bigger problems beside just kind of individual cases. That really opened my eyes to entrepreneurship, startups, and just what the possibilities were for a physician. And kind of made that pivotal switch to emergency medicine for me to pursue my product and company at that time, before finishing my second residency and coming here to the Bay Area.
Oh wow, that is quite a story. So it sounds like so you were doing cardio thoracic surgery, ended up switching to emergency medicine, but built a whole company in between that somehow.
Yeah, it was it was an early start, and it would say, company is a strong word. I would say it's a startup, and obviously there
Okay.
was definitely a minimally viable product MVP. But it was actually using kind of the early stages of AI with computer vision to track surgically retained objects. And then just realizing the power of kind of the early stages of artificial intelligence at that point, and be able to do and take over a lot of monotonous and manual tasks. As you probably know, Adam, having been in the OR as a resident or as a medical student, we do a lot of manual tasks, including just basic stuff like counting the number of sutures and gauze and other surgical items inside the body cavity to make sure nothing is retained. But that repetitive task could be automated with AI at that point.
Got it. Very cool. And so, what are you currently doing now? Are you still in practice, or and I know you're definitely big into the world of entrepreneurship, which is something I'm
Yeah.
interested in as well. So, how have you leveraged kind of this unique experience after that?
Yeah. Yeah, it's a great question, Adam. And I think, to tackle any problem, you really do have to have that firsthand experience to understand that pain point. Um, Fortunately, but also unfortunately, really kind of felt that pain point when I was recruited here to Northern California to be part of the leadership and take over the leadership administrative side of a department and be on the hospital executive side. This is obviously right, at the beginning and cusp of COVID-19's pandemic, and really uh, a lot of demand for the clinical operation sides, but also I didn't realize that there was a lot of decision making on the financial operation side, and what that meant was just getting our physicians paid, and kind of delved into this world of revenue cycle management, which is just a fancy word for medical billing. Getting us paid for our claims and for our services provided to patients. And didn't realize that this was a very complex, fragmented, and legacy problem. And that a lot of services that we provide, 15-20% of that, we're not actually paid at all. And in emergency room, unfortunately, that's much higher because a lot of uninsured patients, a lot of homeless patients, and underserved patients in general. And it's hard. It's hard because physicians want to get paid fairly. And then, as you probably know, during the pandemic, there was a shortage, quote unquote, of physician jobs and positions out there because of the lower volumes in the hospitals and emergency room due to the lockdown. And so, understanding that pain point, kind of understanding that there were a lot of vendors and companies out there that did not really solve my pain point. Led me to really open up this whole venture of trying to tackle it on my own.
Got it. Very cool. So, I mean, yeah, that's definitely even for myself because I'm finishing up my third year of training. My goal is to start a private practice relatively soon. And I'm thinking, how am I going to go about, negotiating with insurers that where
Yeah,
it's just a solo provider, or maybe I end up with a few
yeah,
physicians in my group and providers. I don't have the same type of leverage as these big health systems.
yeah.
What are some of the issues you've seen with that? And is that kind of like what your solution is geared towards? Could you go into that a
Yeah,
little bit more?
yeah, definitely, definitely. And Adam, let me just a compliment on how, based on our previous conversation, how much you know, just as a resident, which is actually more than some of the physician owners out there. And the reason I highlight this is because, I know you're very resourceful and you kind of go deep into anything that you tackle, which is amazing for somebody your age. B, most physician owners we're not very savvy. Like it's not like we go to medical school and be like, well, let's take an accounting class. Let's do a mini MBA, right? A lot of
Right.
physicians now it's all the rage, right? A lot of physicians actually pursue an MBA. But 5, 10, 20 years ago, no, I mean that's not like at the forefront of why you go into medicine. So, unfortunately, we kind of concede a lot of that control to our office manager or to a CFO or to somebody who has a little bit more financial savviness to you, meaning that we lose our finger on the pulse of how well we're doing as a practice. And this is exactly what you highlight, Adam, is that it's particularly true for smaller and medium sized physician groups, independent groups that are private, or even some larger conglomerations under managed service organizations actually not very well run, despite the outside perception. So, for me, I actually went through multiple vendors of billing companies and realized most of this was done offshore, meaning in Pakistan, Philippines, India. And not to be geographically biased here, but at the end of the day, I look at results enough where I did my due diligence and had these one-to-one video sessions with the billers to be like, well, I want to see how you're doing billing because at a certain
Right.
point we lost 40% of our revenue and realized they made a lot of manual clerical mistakes, didn't have the medical knowledge to understand how to appeal denials, weren't coding correctly, And sometimes they're coding for directly under the physician assistant and not the physician attending, which, as you know, affects the reimbursement rate. So I was like, well, okay, that makes sense. Now I know why we're losing so much money for our department. Not to mention the fact that it's during the pandemic. Um, so once I was looking for a better solution, I realized there was none. And when there was none, I was like, okay, there has to be something more novel, innovative, and more physician friendly out there in the market. And that is something what I sought to create as a end to end turnkey solution for physician owners and practices.
Got it. Awesome. And I definitely want to hear more about that solution specifically. But just to summarize the problem for you, because like as I'm looking into how I'm going to start my own practice, right? I'm meeting with different EHR companies just to
Yeah,
see because you're probably not using Epic if you're starting up your own solo practice,
exactly.
and
Yeah,
every single one of these companies they also have like a billing services alongside the EHR where they say, hey, we're gonna collect on your behalf. Some of them are like a flat fee, other of them take a percentage of what they collect, versus, I guess, having your own biller that you pay in house. I guess,
yeah,
one, do you have any? And it sounds like that's just been challenging for many physicians to actually collect on all their claims, both from like the logistical standpoint and also because I know insurance companies sometimes make it difficult to pay out all the
yeah,
claims that
yeah,
you should be entitled to.
yeah.
Is that kind of what the core of the problem is? And then does that like make sense as a summary? And then what is your turnkey solution to that?
Yeah, yeah, exactly. And you actually highlight a lot of the important points, Adam. Is that a it's we're playing games, unfortunately, with the insurance payers, right? So to give you some examples, like sometimes you can bill everything, you can code correctly, the bill is filled out, the claims is filled out exactly the way it should be, you have prior authorization, there's no clerical mistakes, and they'll still deny you, right? And a lot of times you're scratching your head, the biller or the office manager is trying to figure out why, and then literally 30 days later you do an appeal, you give the exact same form, and then all of a sudden it's approved, right? And you get the full reimbursement. So you're like, wait a minute, there's no rule here. There's no logic. It's just like some arbitrary rule. And that's the problem sometimes. I'm not saying that's 100% of all why, some of these claims are denied, but there's so much leverage and arbitrary control on the insurance payer side that we're really at their mercy. Not to mention, obviously, very faulty AI algorithms out there that's employed by some of the large insurance payers, which was obviously highlighted by the recent events with the shooting. So part of it is we're using technology to fight against technology, right? For the ones that are not just completely arbitrary. B, exactly like you said, it's just a very tedious manual labor, and with obviously the recent inflation costs, it's impossible to just keep on hiring more and more billers. It's just not a very efficient way to run a business, right? You can't just keep on increasing your headcount and be like, well, I'm gonna have somebody who just do my denials, and then I'm gonna have somebody just do my prioritization. I'm gonna have somebody just do my billing in general, and then like, well, I'm a solo practice. I can't have two or three people to do all my billing, right? And then lastly, believe it or not, in the day age of information of what we're in now, where we have too much information, you can't figure out what's real, what's not. You actually cannot break down your own financial data very well. Meaning that, like, I don't know which codes reimburse me the best. I don't know which insurance payers, perform the best. And that's, as you mentioned, Adam, very important for contract negotiations and also which insurance payers to keep. So the core essence of all these problems is data, transparency, B, manual labor, and C, kind of just having that trust and being able to have full confidence a service is going after every claim and after every denial. And so, and that's kind of the core essence of our product. And most importantly, this is built by a physician for physicians. And I truly understand the pain point of anybody running the practice, whether it's a solo practice to a large department organization. So we're working with one of the premier AI scientists, working with one of the best operator minds in the field, somebody who actually beat Google in early enterprise AI search to build, the leading AI agent and one of the few AI agents that tackles this problem of billing. And honestly, as a physician owner and as a previous department head, I kind of don't want to think about billing in general. I just want you to take away
Right.
that problem, be like, show me the money. Like, I'm doing really well. We're working really hard. Just make sure, I just want to make sure I can trust you to handle my financial operations and that we can get a steady revenue month to month. And I have the data to understand what procedures, what surgeries, what types of cases make the most sense for our department. And so that's kind of what we really aim for in terms of service as well as from the technology side.
Yeah, no, that makes a lot of sense. I like how you said fighting technology with technology. It's in the world of AI right now. It seems like, and I know what you're. I assume you're referencing United Healthcare, how they had like an AI that was just basically auto
Yeah,
denying claims from even if they like didn't fully evaluate those claims, and I think
yeah,
there was like an extremely high error percentage on those
yeah,
denials.
yeah,
Yeah, so that's
yeah,
just like that's something that
yeah,
makes me nervous
yeah,
starting a practice is am
yeah,
I just beholden to these insurance companies? So it's great to hear that there are tools like that
yeah,
um, that you're building and that others are building using this technology.
yeah,
And so would you say, I mean, I like to say like the pendulum can always swing back because I know we were going towards like big academic institutions and big healthcare conglomerates buying up private practices and private
yeah,
equity. Do you see the pendulum swinging back towards like the
yeah,
independent physician with tools
yeah,
like the ones that you provide, or like what do you how do you see
yeah,
the landscape unfolding
yeah,
over the next 5 years?
yeah. Great question, Adam. And I think how well we do financially as physicians and physician owners goes hand in hand with that the swing of independent practice versus the monopolization and corporatization of medicine. And exactly what you're talking about, there's no accountability on the monopolization and corporatization of medicine, especially on the payer side. And they're just not, as you know, they're not just payer insurance, right? Like United Healthcare owns like everything, right? The provider
Right,
side
literally,
with
yeah,
Optimum, they own the clearinghouse with Change Healthcare, they owned like the payment system called Echo, like
right,
every major component of this large machine that's called healthcare is owned by some of the biggest insurance payers, right? Um, so, but like the exact AI tool that you mentioned for United, it's called NH Predict. It had a 90% error rate, right? And there's no accountability
right.
for that
It's
until like,
crazy.
oh, by
That's
the
crazy.
way, yeah, right. Imagine if you had a biller, Adam, let's say when you have your practice, you're like, by the way, your biller has a 90% error rate. You're gonna be pulling your hair out, be like, I gotta fire you. I can't like
Yeah.
keep you if you have a 90% error rate. So there has to be accountability on the insurance side and the monopolization of that. So I think once there are policies, once there's more, obviously there's assembly bills actually, for example, here in California that scrutinizes how AI is kind of the last filter on whether prior authorizations or claims are truly denied. There has to be quote unquote human physician supervisions at the end of the day in terms of that claim or prior authorization. I think that's one of the policy changes that need to come about. On top of that, there probably will be a swing of private equity ownership of urgent cares, ambulatory surgery centers, hospitals, et cetera, et cetera. So one of the kind of disturbing but kind of very disheartening trend from 2012 to 2022, I believe, and I think uh, private physicians went from 60 something plus percentage to like less than half to like 45%, 44, 45% over that decade. And that's exactly some of the major forces and policies that have come into play where insurance players are buying out, large physician groups. Private equities are buying out both facilities and providers and looking at the more lucrative specialties like orthopedics, spine, urology, etc. Right. So once we kind of see this seesaw balance out a little bit, I think we're probably reaching a breaking point where independent physicians really need to kind of build a community to understand each other and help each other, and with the right engine to kind of move this car forward with the financial operations, with revenue cycle management, with medical billing specifically.
Yeah, no, that makes sense. And my hope is like being able to utilize tools like AI will hopefully make the ability to run a private
Yeah,
practice more efficient, right? Like I know a
yeah,
lot of people, had to employ scribes, right, to try and see enough patients in time. Now we have
yeah,
the AI scribes coming.
yeah,
It seems
yeah,
like they're getting there in terms of where they'll be able to just listen to your conversations with patients and essentially write the note based on that
yeah,
conversation.
yeah,
And so I'm hoping these tools you could leverage to have a private practice and fight back against this just the difference in resources between some of these bigger health systems. Are you
yeah.
seeing anything in AI, since I know you're much more familiar in that space, besides from a medical billing standpoint, that you think is going to affect healthcare? I know like we had the whole DeepSeek controversy recently
Yeah,
that just
yeah,
came out.
yeah,
I actually tried it out. I mean, it seemed pretty similar to Chat GPT. Um, and there's like I feel like every other day there's a new
yeah,
AI tool coming out. Where do you see that as how it relates
yeah,
to changing
yeah,
healthcare?
yeah. Let me take a step back and speak as a physician who understands technology, but I am not an AI engineer or scientist. And having been kind of been in this recently, and obviously getting a lot of my expertise, insights from our CTO, who did his whole. He's been building AI for more than a decade, and from his undergrad to his PhD, and actually trained under the chief AI scientist at Amazon Web Services, as well as Oracle and Cerner. I say this because I want to speak a little bit more in layman terms for our physician and kind of practice owners out there. Uh, I think separating foundational models like ChatGPT, Anthropic, and then DeepSeek that came out, to more kind of the second layer, which we call the application layer, in terms of that vertical application of, like, for example, tackling billing, tackling scribing, et cetera, et cetera. Um, I think foundational models will not really affect us that much from a practical business and physician uh, application side. But and as you know, these foundational models are built on like benchmarks, testings of like standardized tests, mathematical reasoning, based on like medical school tests and all these other
Right.
things. And as you know, that's not like as great as as some of the best step one, step two takers. It may
Right.
not be the best clinician, right? Or
Yeah.
may not be the best physician business owner. Now, does that mean we ignore great breakthroughs or great foundational models that are emerging? No, I think we should definitely understand where that comes in. And you and I were just discussing this. I had a few patients that came in and were like, "Hey, I self-diagnosed my peripheral arterial disease based on my interpretation of my ankle brachial index of 0.65. But like, I think I am indicated for this medication, and maybe I should get an angiogram. And should I get a stent?" Now, mind you, this is like an engineer here in like Silicon Valley who's like giving this like
but
information. I was like, are you giving me medical recommendations on what I should do? Or are you just like, but I was like,
and
as
and just to clarify, that came from one of the AIs they were using, right?
exactly, they're
Yeah.
using, it
Right.
was
Yeah.
specifically DeepSeek, right? It was
Right.
DeepSeek. I was like, well, this is a very assertive recommendation, although it is actually pretty accurate. And yes, you do probably need an angiogram, and then we do need to evaluate PAD. Is this a true emergency? Is this like acute limb ischemia, or is this like chronic, or is this like is this more like diabetic neuropathy, or like what are you really having here? But I was very impressed by this level of reasoning. So I think it's important for physicians, getting back to the core principle here, is that we need to be aware of what's out there from a technology standpoint and what AI can do and can't do. And I think the biggest and most critical fundamental piece for physicians, for just lay people, is that we need to know when AI should be applicable and when it shouldn't. And
That's a good
AI
point.
really excels at like really doing a lot of monotonous tasks where there is some type of kind of basic layer of logic. And I don't want to make this sound something called like RPA, which is kind of robotic processing automation, where it just literally just kind of copies the movement and clicks of physicians or users. But there is some basic level of reasoning in there to really create an outcome. And that outcome could be like, I want to get paid for seeing a patient, right? I want to have a better medical content for my soap note, so it actually describes the medical decision making better so that I can code better, so I can actually get approved for this visit. I think that specific vertical application is very, very important. Um, Now, do I expect it to be like a co-pilot in terms of like medical decision making? And I know people love to use like radiology studies. Or like, well, you know,
Right.
this AI can detect this tiny ounce of hemorrhage on the CT scan versus like a really 10-year veteran who's a radiologist. Um, yes and no, in a sense that I think at this point it is always going to be that quote unquote co-pilot or supplementary to make sure we don't make mistakes. Are we at the point where it takes over the clinical decision making and that final outcome? I don't think we're there yet. But anything happen, and this technology, as you know, is moving so quickly. Every 3 to 6 months, we see a new development, we see a new model come out there. So for physicians and owners and people who are running the back offices of healthcare, you need to be in tune and aware of what's going out there, or honestly, you're not going to be able to compete or do well.
Yeah, no, these are all really good points, and I agree. I mean, I think that would be very crazy at this point to like have the final say on a radiology read be a AI. Like I feel like this is my thought when people ask me about radiology. I mean, you let me know if you think this is out of touch. But my thought is like you might have a radiologist who can do more, one individual, because they use the AI as the assistant. But I don't
Yeah,
think it's going to replace radiologists because right now that there just has to be human
yeah,
oversight to some
yeah.
degree.
Yeah, yeah, and that's a great point. But with some of the AI technology out there, they're already out there in a sense that they are still detecting, like with CT perfusion scans, and sometimes with just the non-contrast CT scan, they will help give their recommendation. And I believe most radiologists will consider that on their read, or they'll go back to their read with
Right.
that supplementary tool. So
Yeah, makes sense. So hopefully overall it just makes
yeah,
physicians more effective at their jobs. I mean, I guess
yeah.
time will tell how fast it can continue to improve to the point that it's replacing physicians. I'm not so sure.
Yeah,
Um,
exactly.
Okay, so as switching gears a little bit, you kind of brought this up before about like legislation in California that makes it maybe less so that claims would be denied just through AI alone, like we saw with United Healthcare. On a federal level, and obviously we just had a change in the presidency, so a whole new administration is coming in. Like as we record this today, RFK just passed the Senate Finance Committee, I believe. So um, I know he's a very controversial figure, but
Yeah,
it sounds like new legislation will be coming in. Is there certain things that, um, like from a policy standpoint for like business, let's getting away from like the medical Maha movement side of it, that you think would be beneficial for physician owners, breaking up, like you mentioned, United Healthcare owning, like essentially it's like a monopoly. I
yeah,
mean, owning the insurance,
yeah,
the PBMs, the having their own provider groups. I mean, the whole thing, like pharmacies. It's that seems like a monopoly to me. But what are your thoughts? And is there any legislation that you're seeing on
yeah,
the federal level that would be helpful for
yeah,
individual physicians?
yeah. Great question. And obviously, RFK is a very controversial topic, and it's a sensitive topic for a lot of physicians. And I think I want to be very understanding of both sides. I would probably see that a lot of physicians are taken aback by some of its policies, from the fluoride, the vaccination, etc., which are kind of more well-established principles of how we practice medicine. But there are certain things, whether you agree or not, is more. Like, for example, like taking a closer look at the role of AMA, the American Medical Association. I do
Hmm.
believe that they play a very big role in our healthcare system, and some of the benefits includes promoting our interests as physicians. But like, why do we have such a complex world of coding of CPT codes? Like, what is the necessity of that? Like, how much of an administrative burden is that on us? So that's something to look at, right? And it's not to say something is wrong or right, but like, what are we creating in the within this healthcare system that is causing us to be so bloated, right? And same with PBMs. It's this recurring theme. I think that people are looking at not only healthcare but just in general in government policy is like, why is it so much overhead? Why is there so much third party play or third party administrators? Why are they really necessary? Are they there just to kind of extend the fat within the administrative bloatedness and burden, or are they actually providing value? And I think, from, pharmacy benefit management, from that standpoint, I think with the price spreading, I think that's kind of a very obvious, glaring problem that's emerged. Um, and the fact that our healthcare system's $4.8 trillion now, approaching 5 trillion, like, what is it, 1.5 trillion is administrative, like,
Right.
bloated burden and fat. Like, how do we skim the fat on that, right? And I think these are the important questions that need to be asked if we really want to make a strong impact on healthcare's operations and how to run it more efficiently. And honestly, it's a lot of back office issues. It's a lot of third party administrators. And at the end of the day, the recurring themes that emerge from this type of questioning are, um, you know, is there too much corporatization and monopoly of medicine? Right? What is the role of private equity once again? And is it really healthy for large healthcare systems just to buy out everybody and there's no competitors? Right? What's the
Right. Yeah.
true democratic and like true capitalistic market in this area? And you can go to certain areas where like there are no independent physicians. You're like, why? Because every large healthcare system has bought everybody out. Just spoke to a physician and in Colorado. He's just like, yeah, dude, there are no independent physicians here. I'm like, why? They're like, everybody who tries to establish something, they just can't compete with the prices. They can't compete with the contracts. And honestly, it's just easier to join a large organization. But when you go get your bill and you get your explanation of benefits for services, they're like, wow, I'm being charged so much more than if I were to go like, 100 miles to this other side to an independent physician. So like, is this really better for
Yeah.
patient care and
I
prices?
I was just gonna ask you that because you know the insurance side well. Like, how is it that facility fees can be different if because it's a large conglomerate
Yeah,
or academic health system or nonprofit versus the private practice physician? And it ultimately, ironically, you would think, oh, that
yeah,
private practice physician is just trying to make money, but that physician actually probably is charging you a lower price, but they
yeah,
just can't
yeah,
get reimbursed at the same rates with insurance companies that the big health
yeah,
system can. And so it's not like a true fair market in that
no,
sense.
yeah, yeah, exactly. It's just I will tell you this to put in very layman terms. There's a lot of double dipping by corporate medicine, by private equity. Of course, there's a very aggressive Stark law against physician ownership or kickbacks on anything we do. But guess what? Guess what? All the large healthcare systems and private equity, why are they buying out the ambulatory surgery centers, right? Why are the large healthcare systems buying out like the ambulatory surgery centers or urgent cares, right? And why are the insurance payers buying out physician groups, right? Their
Yeah.
profit is capped at a certain percentage. They're like, well, let me bypass this and own the physician group and recapture that profit
Yeah.
margin
Or
back to us, right? Yes, we have to spend approximately 80-85% on patient care services and provider services, and then we can't make too much money. However, we can make up for that lost gap in margin by buying out like the entire cycle of care. Um, so like,
yeah.
where's the
And
fairness in that?
Yeah, exactly. You just hit on two important points I kind of want to highlight. One is so I think this was under the ACA, which maybe like the intentions were overall good, right? They were going to set a
Yeah,
cap on you can only your profit
yeah,
margins. I think what could be about 20%, right?
yeah.
Or sorry, 20% has to be the 80% it needs to be used towards like healthcare services of the premiums you collect for the people that are paying out those premiums. But how do you get around that if they say that you get to have 20% profits of the whole pie? You just make the pie bigger. So the premiums go up, and then their 20% number is just larger on higher premiums. And then the second thing was that these insurance companies with the Stark laws, so I can't like there can be no financial ties between me and let's say I want to refer to a physical therapist or an orthopedist. There can't be any financial ties for me to benefit from the referral. I need to go buy out the orthopedic group or own the physical therapy group, which is essentially what these big systems are doing. It's kickbacks, but they just own everything. So there's no they're allowed to do basically bypass Stark. Is that like a good explanation, or is that like how they're kind of getting around? Is just they own everything?
Yeah, exactly. It's like, well, okay, I'm gonna limit my profit for this segment, then thus I'm gonna go more downstream. I'm gonna go more downstream. And like I said, this goes back to that, a glimpse of like United Healthcare's power, right? Like I said, they're not just an insurance payer. They're one of the largest provider groups under Optum. They're one of the largest, if not the largest, middlemen with the clearinghouse under Change, right? And then on top of that, they also are own the whole entire payment system with Echo, right? So it's just like if you own the whole like uh, water system, guess what? You have a monopoly on the prices, right? So at the end of the day, that's what and when from a federal level, from a government inspection or introspection on these issues, is this is where we need to look at, right? And so it's like the leverage, like we as physicians at this point, we honestly, you know why we're burnt out? Let me be honest with you. We're not burnt out because we're it's a small portion. I don't want to dismiss it. It's not because we're writing so many notes. It's not because like we're told to come in at 7 a.m. instead of like 8 a.m. It's not that we're only just being overworked. The reason we're being overworked, the reason that we're clinically burnt out, is because we're paid unfairly and because we have no leverage, we have no say in any of these negotiations or any type of discussion on a larger scale. So
Right.
this is ultimately why we're burnt out.
Yeah, no, that makes sense. It'll be interesting to see what happens if new legislation is passed uh, to hopefully fix some of these issues. Also, I do think like physicians almost have to come together because I know you mentioned the AMA before, but it seems like they're lobbyists, but I don't know. I mean, there's definitely I'm sure some good things about the AMA, but it seems like we need more of a grassroots physician
Exactly.
advocates. So
Yeah. Yeah.
hopefully these things will start to change. Hopefully with the different tools like the ones you're building with revenue cycle management and AI in general to hopefully make the physician job easier. We could see more independent practices pop up, more competition, which not only will help physicians but also be better and give more choices to patients. So very insightful discussion. I really enjoyed it. I think we covered a lot of intricate topics within the healthcare system, and I definitely hope to do this again. So I really thank you for coming on. And where can our listeners find you if they want to learn more about what you're doing?
Yeah. Thank you, Adam. And like I said, thank you for having me here. And I think it's really important for physicians like ourselves to have that voice and really kind of come together and build that grasp of influence to be able to have a voice in the say of a lot of decision making on how we practice and how we're paid and what our future is going to be like. So you can guys follow me at ulify.com, ulify, YOULIFY .ai is an actual company that we provide services, be able to really help physicians. Even if you don't use this, this is not to market ourselves, but really when a lot of people come to me privately as well to kind of be like, how do I go about this, right? Because honestly, to be independent physician owner to navigate this whole world of insurance payers is not easy. It is very, very complicated. And I think, sessions like this, discussions like this is actually what really raises that awareness and education level of how physicians should practice. And honestly, like I said, we didn't go to an MBA, we didn't go to an accounting class to learn about the business side of healthcare. But unfortunately, this is not only a supplementary portion of our journey in healthcare now. I think it's a mandatory and necessity for us to be successful and to survive in this new day and age.